Hi everyone, this is Doc Ina and welcome to my updated lecture on normal labor and delivery. To download this lecture deck, please go to my WordPress site, Docina Obigaine. Reference for this lecture is the latest edition of Williams Obstetrics, that's the 25th edition, Chapter 22, Normal Labor. And here's the outline of this lecture. So first, let's review some basic concepts and the mechanisms of normal labor. So first, pelvic floor changes. So many adaptive changes are required for pregnancy and for labor and delivery. And so some experts have actually measured the bladder neck mobility in the area within the urogenital hiatus during Valsalva. Now this hiatus is the U-shaped opening in the pelvic floor muscles through which the urethra, vagina, and the rectum pass. Now, experts have shown that the urogenital hiatus area significantly becomes larger at 37 weeks AOG and at 6 weeks postpartum compared with early pregnancy, and the size goes back to its original size by 6 months postpartum. Next concept is the fetal lie. So at the onset of labor, the position of the fetus with respect to the birth canal is critical to the route of delivery, and thus this should be determined in early labor. So the fetal lie describes the relationship of the fetal long axis to that of the mother, and we have three types. That's longitudinal lie, transverse lie, and oblique lie. So in 99% of labors at term, the fetal lie is actually longitudinal. The transverse lie is less frequent, and the predisposing factors for transverse lie include multiparity, placenta previa, hydramnios, and uterine anomalies. Occasionally, the fetal and maternal axis may cross at a 45-degree angle, forming the oblique lie. The next concept is fetal presentation. So the fetal presenting part is the portion of the fetal body that is either foremost within the birth canal or in closest proximity to it. So this can be felt or determined using internal examination. And we have four subtypes. We have cephalic, breech, shoulder, and compound. So for the cephalic presentation, we have four types. So as you can see in this picture here. Now, these are classified according to the relationship between the head and the body of the fetus. So ordinarily, the head is flexed sharply so that the chin contacts the chest or the thorax, as you can see here in this picture. So the occipital fontanelle is the presenting part, and this presentation is referred to as vertex or occiput presentation. Much less often, the fetal neck may be sharply extended, as you can see in this picture here, so that the occiput and the back are in contact or nearly in contact. So in this case, we have the face of the fetus presenting at the birth canal, and this is what we call face presentation. The fetal head may assume a position between these two extremes. Okay? So when the head is only partly flexed, such as you see in this picture, the anterior or large fontanelle may present at the birth canal, and this is what we call sinciput presentation. Now, when the neck is only partially extended, as you can see in this picture, the brow may emerge, and this is what you call brow presentation. These two presentations are actually transient. So as labor progresses, sinciput and brow presentations almost always convert into vertex or face presentation by neck flexion or extension respectively. Failure to do so can lead to dystocia and thus be delivered through a cesarean section. So for breech presentation, we have three subtypes. We have complete breech, incomplete breech, and frank breech. The incidence of breech presentation drops with gestational age and approximates 3% at term. Breech presentation may result from circumstances that prevent normal version from taking place. One example is a septum that protrudes into the uterine cavity. Variances of fetal attitude, particularly extension of the vertebral column as seen in frank breeches, also may prevent the fetus from turning. If the placenta is implanted in the lower uterine segment, it may also distort normal intrauterine anatomy and result in a breech presentation. The next concept is the fetal attitude. So in the latter or later months of pregnancy, the fetus assumes a characteristic posture described as fetal attitude or habitus. As a rule, the fetus forms an ovoid mass that corresponds roughly to the general shape of the uterine cavity as you see in this picture. So the fetus becomes folded upon itself to create a convex back. The head is sharply flexed as you can see in this picture, and the chin is almost in contact with the chest. The thighs are flexed over the abdomen and the legs are bent at the knees. In all cephalic presentations, the arms usually lie across the thorax or parallel to the sides. The umbilical cord fills the space between the extremities. The characteristic posture results from the mode of fetal growth and its accommodation to the uterine cavity. The next concept is fetal position. So position refers to the relationship of an arbitrarily chosen portion of the fetal presenting part to the right or left side of the birth canal. So how do we determine fetal position? So first, imagine yourself as the obstetrician who will deliver this baby. No? So your perspective is that you're looking at the vaginal area of the patient. Okay? So the patient is lying in a dorsal lithotomy or supine position. Okay? So this is anterior because this is where the symphysis pubis is. This is posterior because this is where the sacrum is. And because you're facing the vaginal area, this will be the maternal left and this will be the maternal right. Now imagine drawing two perpendicular lines across this pelvic cavity, like a cross. Okay? So for a fetus in the vertex or occiput presentation, such as this one that we see in this picture, our landmark will be the occipital or posterior fontanelle, which in this drawing you see as the fontanelle that's triangular in shape. Okay? So, if the occipital fontanelle is pointing towards this direction, then the fetal position is occiput anterior. If it's pointing this direction, this is LOA or left occiput anterior. This is left occiput transverse, left occiput posterior, occiput posterior, right occiput posterior, right occiput transverse, and right occiput anterior. So in this picture or example that we have here, this is a fetal position at left occiput anterior because as you can see, the occipital fontanelle is pointing this way. Okay, so let's do some exercises. Okay, so as you can see in this picture, we have the occipital fontanelle pointing in this direction. So this is left occiput anterior. For this picture here on the right, we have the occipital fontanelle pointing downward and in this maternal left side. And so we have left occiput posterior. Okay. Next is we have right occiput posterior because the occipital fontanelle is pointing this way. And lastly, we have right occiput transverse. So, for other fetal presentations, we have other landmarks. Okay, so for a baby or a fetus in face presentation, we use the mentum or the chin as our landmark. For a baby or a fetus in breech presentation, we use the sacrum as our landmark. And finally, for a fetus in shoulder presentation, we use the acromion or scapula as our landmark. So let's do some exercises. Okay, so this picture in the upper panel is obviously a fetus in face presentation and therefore we use the chin or mentum as our landmark. So this chin or mentum is pointing in this direction. So this is left mentum anterior. The next picture, we have right mentum anterior. And the last picture, we have right mentum posterior. This picture on the lower panel is obviously a fetus in a transverse lie and therefore we have a fetus with a shoulder presentation. So this fetal position is right acromio-dorso-posterior. And finally, okay, so we have a baby or a fetus in breech presentation. Okay, so we will use the sacrum as our landmark. So in this picture here, we have the sacrum pointing this way. Okay, so this is left sacroanterior. Next picture, we have left sacrotransverse. And the last picture, we have left sacroposterior. Okay, so the next concept we will review is the Leopold maneuver. Several methods can be used to diagnose fetal presentation and position, and abdominal examination can be conducted systematically employing the 4 maneuvers that are originally described by Leopold in 1894, and the pictures or maneuvers are shown in this slide. Okay, so the mother, in doing your Leopold maneuver, the mother will lie supine and positioned with her abdomen bared. These maneuvers may be difficult though to perform and interpret if the patient is obese, if the amniotic fluid volume is excessive, or if the placenta is anteriorly implanted. So for Leopold maneuver 1, this is the first maneuver. Okay, this assesses the uterine fundus. Okay, so you have 2 hands assessing the fundal area of the uterus, and this permits identification of fetal lie and determination of which fetal pole, that is a cephalic or podalic, that occupies the fundus. Okay, so the breech will give the sensation of a large nodular mass, whereas the head will feel hard and round and is more mobile. Now for Leopold maneuver 2, okay, this is accomplished as the palms are placed on either side of the maternal abdomen. Okay, and gentle but deep pressure is exerted. On one side, a hard resistant structure, such as you see here, can be felt, and this will be the fetal back. Now on the other side, numerous small irregular mobile parts can be felt, and this will be the fetal extremities. By noting whether the back is directed anteriorly, transversely, or posteriorly, fetal orientation can be determined. And it is also very important to do Leopold maneuver 2 because you want to determine the fetal back so that you know which part in the maternal abdomen you will put or you will place your stethoscope or fetal Doppler so you can appreciate the fetal heartbeat or the fetal heart rate. Leopold maneuver 3 aids in the confirmation of fetal presentation. The thumb and the fingers of one hand, as you can see in this picture, grasp the lower portion of the maternal abdomen just above the symphysis pubis. If the presenting part is not engaged, a movable mass will be felt, usually the head. The differentiation between head and breech is made as in the first maneuver. Now last, which is Leopold maneuver 4, this helps determine the degree of the descent. The examiner faces the mother's feet and the fingertips of both hands are positioned on either side of the maternal abdomen, and then you slide both hands towards the axis of the pelvic inlet. So in many instances, when the head has descended into the pelvis, the anterior shoulder or the space created by the neck may be differentiated readily from the hard head. Now, with the onset of labor and cervical dilatation, fetal presentation and their positions are easily recognized by palpation of the various fetal sutures and fontanelles by doing a vaginal or internal examination. Now, the face and breech presentations are identified by palpation of facial features or the fetal sacrum and perineum, respectively. During this internal examination, it is advisable to pursue a definite routine comprising of 4 maneuvers. So first, the examiner, of course, should insert 2 fingers into the vagina and determine the fetal presenting part. Differentiation of vertex, face, and breech should be accomplished. So secondly, if the vertex is presenting, such as you see in this picture here, the fingers are directed posteriorly, okay, and then swept forward or upward over the fetal head towards the maternal symphysis. Okay? During this movement, the fingers necessarily cross the sagittal suture and its linear course is delineated or determined. Next, positions of the two fontanelles, whether this is the anterior or the posterior fontanelle, found at either end of the sagittal suture are ascertained. Now for this, fingers are passed to the most anterior extension of the sagittal suture, and the fontanelle encountered there is examined and identified. So usually we identify them by determining its general shape. So if it's a triangular fontanelle, then that's the posterior fontanelle. If it's a fontanelle that's roughly diamond in shape, then that will be the anterior fontanelle. And then the fingers pass along the suture to the other end of the head, no, until the fontanelle is felt and differentiated. So last, the station or extent to which the presenting part has descended into the pelvis can also be established by doing the internal examination. So using these maneuvers, the various sutures and fontanelles are also determined. So for a fetus in cephalic presentation, some fetal head shape changes may occur. So in prolonged labors before complete cervical dilatation, the portion of the fetal scalp that is immediately over the cervical os becomes edematous, and this swelling is known as the caput succedaneum. It usually attains a thickness of only a few millimeters, but in prolonged labors, it may be sufficiently extensive to prevent differentiation of the various sutures and fontanelles. More commonly, the caput is formed when the head is in the lower portion of the birth canal, and frequently only after the resistance of a rigid vaginal outlet is encountered. Now, because it develops over the most dependent area of the head, one may deduce the original fetal head position by noting the location of the caput succedaneum. Another fetal head shape change that may occur is called molding, and molding refers to the changes in the bony fetal head shape as a result of external compressive forces. This is possibly related to Braxton Hicks contractions, and some molding actually may develop before labor. And most studies indicate that there is seldom overlapping of the parietal bones because a locking mechanism at the coronal and lambdoidal sutures actually prevents such overlapping. Molding results in a shortened suboccipital-bregmatic diameter and a lengthened mentovertical diameter. These changes are of greatest importance in women with contracted pelvis or asynclitic presentations. Now, in these circumstances, the degree to which the head is capable of molding may make the difference between spontaneous vaginal delivery or being delivered by a cesarean section. Now, let's go to normal labor. Okay, so the strict definition of labor is uterine contractions that bring about demonstrable effacement and dilatation of the cervix. Now, this does not easily aid the clinician or the obstetrician in determining when labor has actually begun, because this diagnosis is confirmed only retrospectively. Now, several methods may be used to mark the start of the normal labor. One defines onset as the clock time when painful contractions become regular, or that clock time when a woman recalled regular painful contractions that occur approximately every 3 to 5 minutes and that led to cervical change. Now we have 4 stages of labor. So the first stage is from the onset of regular contractions up to full cervical dilatation. So for the full cervical dilatation, it means that the cervix has reached 10 centimeters. Okay? Second stage of labor is from full cervical dilatation up to delivery of the fetus. This is that stage when you see the mother actively pushing out her baby. Okay? Third stage is from the delivery of the fetus to the delivery of the placenta. And lastly, the fourth stage is 1 hour from the delivery of the placenta. So we reviewed the concepts under first stage of labor. This again commences from the onset of regular contractions up to full cervical dilatation or a cervical dilatation that is equivalent to roughly 10 centimeters. So Friedman in 1954 described a characteristic sigmoid pattern or S-shaped pattern by graphing cervical dilatation against time. Okay? So Friedman developed the concept of 3 functional labor divisions to describe the physiological objectives of each division. First, okay, so we have the preparatory division. Although the cervix dilates a little, its connective tissue components change considerably. Sedation and conduction analgesia are capable of arresting this labor division. The next division is the dilatational division, during which dilatation proceeds at its most rapid rate, and this division is unaffected by sedation. And lastly, we have the pelvic division, which commences with the deceleration phase of cervical dilatation. And the classic labor mechanisms that involve the cardinal fetal movements of the cephalic presentation takes place principally during this division. In actual practice, however, the onset of the pelvic division is seldom clearly identifiable. So as you can see again in this picture, the pattern of cervical dilatation during the preparatory and dilatational divisions of normal labor assumes an S-shaped pattern or a sigmoid curve. Okay, this is a sigmoid curve. There are two phases of cervical dilatation, the latent phase and the active phase. Friedman further subdivided the active phase into the acceleration phase, the phase of maximum slope, and the deceleration phase. The latent phase corresponds to the preparatory division, while the active phase corresponds to the dilatational and pelvic division. So let's talk about the latent phase first. Okay, so the onset of latent labor, as described by Friedman in 1972, is the point at which the mother perceives regular contractions. The latent phase for most women ends once cervical dilatation achieves 3 to 5 centimeters. This threshold may be clinically useful, for it defines dilatation limits beyond which active labor can be expected. However, so in 2016, the Consensus Committee of the ACOG and the Society for Maternal Fetal Medicine has redefined active labor to begin at 6 cm. And now this is the threshold for active labor that we are using nowadays. Okay, not anymore the 4 centimeter rule or cutoff. We are now using the 6 centimeter cutoff as recommended by the Consensus Committee of 2016. Now, the second phase of labor is what we call the active phase of labor. So, in the past, we used the 4 centimeter threshold to define the start of the active phase of labor. But since 2016, the Consensus Committee of the ACOG and the Society for the Maternal Fetal Medicine recommended a 6 centimeter cutoff or threshold for the start of the active phase of labor. Descent commences at 7 to 8 centimeters in nulliparous, becoming most rapid after 8 centimeters cervical dilatation. Now we go to the second stage of labor, and again, this commences from full cervical dilatation up to the delivery of the baby. The median duration for the second stage of labor is approximately 50 minutes for nulliparous and about 20 minutes for multiparous. In a woman with contracted pelvis, with a large fetus, or with impaired expulsive efforts from conduction analgesia or sedation, the second stage of labor may become abnormally long. Okay, now this graph is what we call the Friedman's curve, because this was recommended by Friedman. And we also call this a partogram or a normal labor curve. As you can see in this graph, we have two lines, one going up, which corresponds to the cervical dilatation, and this assumes, as I've already mentioned a few slides back, this assumes a general shape of a sigmoid curve. Okay, and the other line corresponds to the fetal descent, and this is the line going down. All right, so the leftmost y-axis will correspond to the cervical dilatation, that will be numbered 0 to 10 centimeters. The rightmost y-axis will correspond to the fetal descent or the fetal station, and that will be numbered -5 or -5 to +5 here. And the x-axis will correspond to the time in hours. Now, for a more detailed and thorough discussion on how to make a partogram, I have a separate video lecture on that, and hope that you can find time to visit and watch that video lecture on how to make or plot a partogram. Okay, so again, this is another depiction of the Friedman's curve. Again, there are two lines that comprise a Friedman's curve or a partogram or a normal labor curve, one going up, which signifies cervical dilatation, and this is plotted using circles, and the line going down, which corresponds to the fetal station, and this is plotted using X. Now we go to the management of normal labor. First, of course, is we have to identify the onset of labor. Now, in the absence of ruptured membranes or bleeding, uterine contractions that come in every 5 minutes apart for 1 hour, that is about or at least 12 contractions in an hour, may signify labor onset. And as I've already mentioned, but I will emphasize it again, active labor is defined as a cervical dilatation of at least 6 centimeters. So we don't anymore use the 4 centimeter threshold. No, we now use the threshold 6 centimeters to define active labor. Women admitted during the latent phase of labor had more active phase arrest, more frequent need for oxytocin labor stimulation, and higher rates of chorioamnionitis. So for the initial evaluation, of course, we determine maternal vital signs that includes blood pressure, heart rate, respiratory rate, and of course, temperature. We also, of course, determine the fetal heart rate or the baseline fetal heart rate. We review the records of the patient to identify any complications. And we do our baseline cervical or internal examination. Okay. Also, part of initial evaluation is to do internal exam and determine if the membranes are ruptured. Awareness of ruptured membranes is important because if the presenting part is not fixed in the pelvis, then umbilical cord can prolapse and be compressed. And ruptured membranes is also a sign that labor is likely to begin soon. Intrauterine and neonatal infection is also more likely as time interval from the onset of the rupture of membranes increases. So how do we diagnose ruptured membranes? First, of course, is we have to ask the patient, or maybe the patient reports fluid leakage from the vagina. Okay, then we confirm this by doing a speculum exam and looking at pooling of the amniotic fluid at the posterior fornix, or if we see clear fluid that flows from the cervical os. Now, if there's not much amniotic fluid that is pooled in the posterior fornix, or you don't see too many fluid flowing out from the cervical os, then we can do pH determination. We test the pH of the fluid that we can get from the vagina. Now, if the pH of that fluid that we got is more than 6.5, then that is consistent with amniotic fluid. Another test that we can do is by doing the Ferning test. So we do this test by getting a sample of the fluid from the vagina or the cervical os and then smearing this on a glass slide and then look at it under the microscope. Then if you see Ferning pattern or arborization, then that suggests amniotic fluid. We can also do injection of indigo carmine into the amniotic sac via abdominal amniocentesis, but of course this will be an invasive procedure, no? Or lastly, we can do detection of amniotic fluid proteins by using Amnisure or ROM+, but of course this will entail added cost for the patient. Now, part of our initial evaluation for a patient in labor is to do cervical assessment, and there are many components for cervical assessment that includes determining cervical dilatation, effacement, cervical consistency, and position. So cervical effacement is the gradual thinning and shortening of the cervix that is measured in percentage. When the length of the cervix is reduced by 1/2, it is 50% effaced. Now, when the cervix becomes as thin as the adjacent lower uterine segment, it is completely, or what we call 100% effaced. So cervical dilatation, on the other hand, estimates the average diameter of the cervical opening that is measured in centimeters. This is approximated by sweeping the examining finger from the margin of the cervical opening on one side to that on the opposite side. Now, the cervix is said to be dilated fully when the diameter measures 10 centimeters because the presenting part of a term-sized newborn usually can pass through a cervix that is widely dilated. Cervical position is determined by the relationship of the cervical os to the fetal head and is categorized as posterior, mid-position, or anterior. Cervical consistency is determined to be soft, firm, or intermediate if between these two. Fetal station is the level of the presenting fetal part in the birth canal and is described in relationship to the ischial spines, which are halfway between the pelvic inlet and the pelvic outlet. So now let me draw your attention to this illustration on the right side of the slide. So when the lowermost portion of the fetal presenting part, as you see in this picture, is at the level of the ischial spines, that is designated as station 0. Or in terms of cardinal movements of labor, that is engagement. Okay? So above the spines, we have the designation of -5 to -1. Okay? Or -1 to -5. That's going up. And below the spines, we have +1 to +5. Okay? So station +5 corresponds to the fetal head being visible at the introitus, or when the fetal head is already crowning. That's station +5. Okay, so part of our cervical assessment is determining the Bishop score. Okay, so the Bishop score is composed of 5 components. We have cervical dilatation, cervical effacement, cervical consistency, position, and fetal station. And this is how we score. Okay, so as you can see in this table, you have a score of 0 to 3, and it corresponds to this specific values in the 5 components. Okay, so whatever total you get, okay, for this each of these 5 components, no, will be the Bishop score. So for example, okay, so you have a 30-year-old parturient who is at the ER, no? And on internal examination, you determine that the cervix is 3 centimeters dilated, 50% effaced, station -1, soft, and anterior. Okay, so compute for the Bishop score. Alright, so how do we compute that? So a cervical dilatation of 3 centimeters corresponds to a score of 2. Cervical effacement that is 50% corresponds to a score of 1. So 2 plus 1 is 3. Station -1 corresponds to a score of 2. Soft consistency corresponds to a score of 2. And anterior position corresponds to a score of 2. So 2 plus 1 is 3, plus 2 is 5, plus 2, 7, and plus 2 is 9. So the Bishop score is 9. So what is the Bishop score? What do we use it for? The Bishop score is a quantifiable method that we use to predict labor induction outcomes. So a Bishop score of 9 conveys a high likelihood for a successful induction. A Bishop score of 4 or less, on the other hand, identifies an unfavorable cervix or an unripe cervix, and this may be an indication for cervical ripening. Okay, so some of the cervical ripening agents that we use are dinoprostone or other prostaglandins. So now for intrapartum fetal monitoring, in the absence of any abnormalities, the fetal heart rate should be checked immediately after a contraction at least every 30 minutes. So you record the fetal heart rate and the uterine contractions every 30 minutes. Okay? If you use continuous electronic monitoring, then the tracing is evaluated also every 30 minutes. However, for women with pregnancies at risk or for high-risk women, the fetal heart auscultation is performed every 15 minutes. Okay? And the frequency is the same when you use continuous electronic fetal monitoring. So for uterine contractions, contractions can be both quantitatively and qualitatively evaluated manually. Using the palm of the hand, resting lightly on the uterus, as you can see in this picture, the time of the contraction onset can be determined. Its intensity is gauged from the degree of firmness the uterus achieves. Okay? So at the peak of the contractions, the finger or thumb cannot readily indent the uterus. Okay? So the time at which the contraction disappears is noted next. This sequence is repeated to evaluate the frequency, duration, and intensity of the uterine contractions. Now, if you're monitoring the contractions, you are very lucky if you have a fetal monitor such as this one in the this picture in the lower panel, because this is already automated and you don't really have to do manual monitoring, no, because you see the intensity of the contractions reflected in the monitor. So how often will you determine maternal vital signs or monitor maternal vital signs? So the temperature, pulse, and blood pressure are evaluated at least every 4 hours. Now, if the membranes have been ruptured for many hours before labor onset, or if there is a borderline temperature elevation, the temperature should be checked hourly. Moreover, with prolonged membrane rupture, that is, meaning if 18 hours have elapsed since the rupture of the membranes, antimicrobial administration for prevention of group B strep infections is highly recommended. So, how often should we perform internal examination? Periodic internal examinations are typically performed at 2 to 3 hour intervals to evaluate labor progress. Now, when the membranes are already ruptured, an examination to exclude cord prolapse should be performed expeditiously if the fetal head was not definitely engaged at the previous examination. The fetal heart rate should also be checked immediately and during the next uterine contraction to help detect occult umbilical cord compression. Okay, how about oral intake? Sips of clear liquids, occasional ice chips, and lip moisturizers are permitted for uncomplicated or low-risk women. However, food should be withheld during active labor and delivery. And this is because gastric emptying time is remarkably prolonged once labor is active, and analgesics are administered. As a consequence, ingested food and most medications remain in the stomach and are not absorbed, and instead, they may be vomited and aspirated during labor and delivery. How about IV fluids? Actually, there is seldom any real need for this in the normal pregnant woman, at least until analgesia is administered. An intravenous infusion system is advantageous though during the immediate puerperium to administer oxytocin prophylactically and at times therapeutically when uterine atony persists. Moreover, with longer labors, the administration of glucose, sodium, and water to the otherwise fasting woman at a rate of about 60 to 120 ml per hour prevents dehydration and acidosis. So for the maternal position, the normal laboring woman or a woman who is not at high risk need not be confined to the bed early in labor. So in the bed, the laboring woman should be allowed to assume any position she finds most comfortable. So this will be lateral recumbency most of the time. She must not be restricted to lying supine because of the resultant aortocaval compression and its potential to lower uterine perfusion. Walking neither enhanced nor impaired active labor and is not harmful if the patient, chooses to walk around the labor room. So how about amniotomy? Okay, amniotomy should not be done routinely. Okay, membrane rupture with the intention of accelerating labor is often performed when labor is abnormally slow. And the presumed benefits of amniotomy are, number 1, more rapid labor, or number 2, earlier detection of meconium-stained amniotic fluid, and number 3, the opportunity to apply an electrode to the fetus or insert pressure catheter into the uterine cavity for monitoring. The ACOG in 2013 recommends the use of amniotomy to enhance progress in active labor, but they caution that this may increase the risk of infection or chorioamnionitis and maternal fever. Fetal head must be well applied to the cervix and not be dislodged from the pelvis to avoid umbilical cord prolapse. So distension of the bladder can actually hinder descent of the fetal presenting part and lead to bladder hypotonia and infection. So periodically during labor, it's very important that we palpate for the suprapubic region, inspect it and palpate it because we want to detect bladder distension. And we must always encourage our parturients to void. Now, if spontaneous voiding is not possible, then we can do catheterization. Now we go to the management of the second stage of labor. Now, as I mentioned earlier, the second stage of labor is when the parturient or our patient is already actively pushing out her baby. Okay, so during the second stage of labor, the woman's legs should be half flexed so that she can push with them against the mattress or the bed. With the beginning of uterine contraction, the patient is coached to exert downward pressure as though she were straining at stool, and this is what we call pushing. Okay? So a woman should not be encouraged to push beyond a completed contraction because we must, give chance for the patient and her fetus to rest and recover. Okay? Now, during this period of actively bearing down during a contraction, fetal heart rate may slow down, but the fetal heart rate should recover to normal after a contraction. So in some countries, they develop what we now call as the active management of labor protocol. So in this protocol, labor is diagnosed when painful contractions are accompanied by complete cervical effacement, bloody show or ruptured membranes. So women with such findings are committed to delivery within 12 hours. So internal examination is done each hour for the next 3 hours and every 2 hours thereafter. So when dilatation has not increased to at least 1 centimeter per hour, then they do amniotomy. Okay? Progress is once again assessed at 2 hours or after 2 hours after amniotomy, and high-dose oxytocin infusion is started unless dilatation of at least 1 centimeter per hour is achieved. So this picture on the right is what you call the WHO partograph, which WHO developed for use in developing countries. So as you can see here, like the Friedman's partogram that I showed you earlier, labor is also divided into the latent phase and the active phase. You can see here, labor is or should last no longer than 8 hours, and an active phase starts at 3 centimeters dilatation. Okay, and the progress should be no slower than 1 centimeter per hour. So a 4-hour wait is recommended before intervention when the active phase is low. So the labor is graphed and analysis includes the use of the alert and the action lines. So how about intrapartum fetal monitoring during the second stage of labor? So for low-risk women, the fetal heart rate should be checked immediately after a contraction at least every 15 minutes. And the frequency is also the same if we use continuous electronic fetal monitoring. Now for high-risk women, the fetal heart auscultation is performed or should be performed every 5 minutes during the second stage of labor. And this is the same frequency we use when we use a continuous electronic fetal monitoring. So now we go to the delivery of the fetus. So the fetus most commonly presents in the occiput anterior position, as you can see in this picture here. And then with each contraction, the vulvovaginal opening is dilated by the fetal head to form a circular opening. And this is what we call crowning. Okay? And the perineum around it thins and may lacerate as the head is being delivered. So currently, experts have recommended against routine episiotomy. Okay? So they no longer recommend a routine episiotomy. Whereas in the past, episiotomy is almost always being done. Nowadays, routine episiotomy again is no longer recommended. Selective use of episiotomy aims to enlarge the vaginal opening only for specific indications. So now when the head distends the vulva and the perineum enough to open the vaginal introitus to a diameter of at least 5 centimeters, you use a gloved hand to support the perineum, such as in this picture that you see here in this slide. Okay, so your other hand is positioned over the head of the baby, and this is to guide and control the fetal head to deliver the smallest head diameter through the introitus and avoid expulsive delivery. Okay, slow delivery decreases lacerations of the genital tract. Alternatively, if expulsive efforts are inadequate or expeditious delivery is needed, then a modified Röntgen maneuver or episiotomy may be done. So how do we do modified Röntgen maneuver? So as you can see in this picture here on the right, with this maneuver, gloved fingers beneath a draped towel exert forward pressure on the fetal chin through the perineum just in front of the coccyx. Concurrently, the other hand, which is on the fetal head, presses against the occiput. Okay? So this is a maneuver that was originally described in 1855, and this maneuver allows controlled fetal head delivery. It also favors neck extension so that the head passes through the introitus and over the perineum with its smallest diameters. Now, following delivery of the fetal head, a finger should be passed across the fetal neck to determine whether it is encircled by one or more umbilical loops. Okay, so umbilical cord that is encircling the fetal neck is what we call nuchal cord. Following delivery of the fetal head can fall posteriorly and bring its face almost in contact with the maternal anus. Now, the occiput will turn toward one of the maternal thighs, okay, to assume a transverse position, and this is what we call external rotation. Okay? So in the external rotation, the bisacromial diameter rotates into the AP diameter of the maternal pelvis. Now, for the delivery of the fetal shoulders and expulsion, the sides of the fetal head are grasped with two hands, and a gentle downward traction is applied, as you can see here in this picture in the upper panel, until the anterior shoulders appear under the pubic arch. Then, once you see the anterior shoulders, an upward movement is done, okay, to deliver the posterior shoulder. Now, during delivery, abrupt or powerful force is avoided to prevent fetal brachial plexus injury. Hooking the fingers in the axilla should be avoided to prevent injury to the upper extremity nerves. Now, in the past, immediate nasopharyngeal valve suctioning of the newborn was routine. However, nowadays, more and more experts are recommending against this practice as this may cause fetal bradycardia. Suctioning is reserved for neonates with obvious obstruction to spontaneous breathing or those who require positive pressure ventilation. So after expulsion or when the fetus is already delivered, we do cord clamping. So umbilical cord is cut between two clamps and placed 6 to 8 centimeters from the fetal abdomen. Umbilical cord clamp is later applied 2 to 3 centimeters from its insertion into the fetal abdomen. So currently, more and more experts are recommending delayed cord clamping, and this is because of so many benefits for the neonate. Okay? So studies have shown that a delay of up to 60 seconds may increase total blood iron stores, expand blood volume, and decrease anemia incidence in the neonate. For preterm neonates, delayed cord clamping has several benefits, including higher red cell volume, decreased need for blood transfusion, and lower rates for intraventricular hemorrhage and necrotizing enterocolitis. So delayed cord clamping has so many benefits that the WHO and the Department of Health of the Republic of the Philippines included this in its essential newborn care protocol. The American Heart Association guidelines of 2015 advise that delayed cord clamping may have benefits for both the term or preterm neonate who do not need immediate resuscitation at birth. The AHA advises against routine use of cord milking for neonates less than 29 weeks AOG due to rapid volume changes. In general, delayed cord clamping versus early cord clamping does not worsen Apgar scores, umbilical cord pH, nor increase rates of postpartum hemorrhage. Now let's go to the management of the third stage of labor. So the WHO has recommended the use of the active management of the third stage of labor protocol. And what does this protocol contain? It recommends, number 1, to give oxytocin or start oxytocin within 1 minute of childbirth. So if the patient has no IV line, you can give oxytocin through IM injection. Okay? So if the patient has already an IV line, then you can start oxytocin infusion by mixing oxytocin in 1 liter of plain NSS. Okay? Do not give oxytocin through direct IV injection. Okay. Second recommendation is to deliver the placenta by controlled traction on the umbilical cord and counter pressure to the uterus. As you can see here, you have an abdominal hand that puts counter pressure to the uterus while you are gently pulling on the umbilical cord. Okay? And the third recommendation is to massage the uterus through the abdomen after delivery of the placenta. Okay, here are the 4 signs of placental separation. You have gush of blood, lengthening of the umbilical cord, uterus rises over the abdomen, and the uterus becomes more globular and firm. And there are 2 types of placental separation methods. The Duncan mechanism is when the maternal or the raw surface is presenting at the birth canal, and the Schultz mechanism is when the fetal surface of the placenta is presenting at the vaginal canal. So, an essential part in the discussion of normal labor and delivery is the topic of cardinal movements of labor. However, I already made a separate video lecture on the cardinal movements of labor. So, I hope that you do check it out, okay? So that you will have a more thorough discussion about this topic. So, that's it for my lecture. So, in summary, we have discussed all of this, no? First, we discuss mechanism of labor, the definition of labor, stages, phases, and functional divisions of labor, and the management of the first, second, and third stage of labor. Thank you for watching this lecture.